Hello, my friends, and I just started my record for the session of today, and I would like to give you an advice before we go, that please, if you are new to the preparation of the part 3, please do it right from the very beginning, okay? And go to the MRCPI resources for the preparation. Like, for example, the Lita Joel book, like, for example, the MRCOG circuit. You remember that day when you have your lovely letter of passing part 2, inshallah, you will have your part 3 letter soon. You remember that day when you receive the pass letter, they advise you there was a resources. If you are starting the part 3 preparation, they advise you with the resources to start on the part 3 preparation. They were too honest. However, many of the candidates, they miss this part. They miss that the college advised resources to start with. Some will even call the Lisa book as a Bible, for the eMRCOG Part 3 exam. It's very useful. It's a very good start. And if you are repeating this exam, so don't worry, don't please doubt yourself. I have complete belief in you guys, and I know that you can pass this exam. You did very well in the part 1, you did very well in the part 2, and you even did very well in your previous trial of the part 3. And passing the exam or not, it's not that much of, that I know better, I should have passed the exam. No, it's not like that. Yes, the element of luck also is there, but the most important thing is sometimes, guys, your nerves fail you down in the exam. This is the thing. And this is a very common thing that I've seen with excellent candidates. Unfortunately, the exam pressure can sometimes go, too much for some people. And that means that some candidates don't end up doing as well as they wanted to, or as they used to be, okay? During the sessions, during the practice, during the preparation for the exams used to be too good. So why did they fail? It's simply because, as I told you, it's the exam pressure sometimes, okay? And don't worry, my friend, it's just a trial. Please believe in yourself and consider it as just a trial. It's not the end of the world. You shouldn't beat yourself up. And it also isn't wise to tell someone else off, if they fail the exam. So simply just try again and stand up tall and, repeat your trial, okay? And go for the exam with confidence. But please, okay, when you go this time, also do right, be honest, and do what is called as a reflective practice. The reflective practice at the college advice is simply that you be honest with yourself, right? You can use a piece of paper and you write down the experience. How did you feel about it? And what do you think, the things that didn't go well, and first the thing that went well actually, and then the thing that didn't go well, and how would you change that in the next time? This is the most important thing, and this is the most important thing we learn from the trials. If you have a certain deficiency, okay, please work on that and start as fresh, okay? Start as fresh and try another way, okay, of the practice. Maybe it's better. According to the standard, I would say that this college is, very keen, okay, actually, to keep the standard and the quality of this exam. They want to keep the MRCOG, the prestigious postgraduate, certificate as it is, okay? It is the most important one and the most prestigious one in our career. Okay, so they want us to keep the same standard, and they will not lower the standard by any means. So my friends, make sure that you are covering the 5 domains required in the part 3 in each task. And today we are going to do a practice for 3 tasks and see, okay, each one of you who wants to volunteer to practice today, how would you cover the 5 domains, okay, in our feedback? So I would like to invite you, my friends, if you want to practice or present the first task. Who would say me? Okay, so Dr. Amira, you're first, and then Dr. Rika, you're second. You're taking the next task, Dia. Is that okay?
Thank you.
Okay, ma'am. Okay, you're welcome, Dia. Okay, so Dr. Amira, please have a look to the task. I will share the screen with you. Can you see it, my dear?
Yeah, I can.
Okay. So, my dear, you have 1 minute. Okay, from now. Then you can start your task.
That's fine. Okay, can I start?
Yes, sure. Okay, so your timer is now. 6, 5, 4, 3, 2, 1. Now on.
Hello, good morning.
Hi, good morning.
Am I talking to Emilia Thompson?
Yes, me, doctor.
Hi, Emilia. I'm Amira. I'm the one of the doctor here in the clinic today. Nice to meet you. May I confirm your
Nice
date
to
of
meet
birth,
you.
please?
Yeah, it's 28 years.
Thank you so much. And can I call you Emilia?
Yeah, sure.
Thank you. Call me Amira. Emilia, I understand from the nurse outside that you are here to discuss your ultrasound report, isn't it? Isn't it, Emilia?
Yeah, yes, doctor. Actually, I'm trying to get pregnant, but I wasn't lucky in the last 1 year. So hopefully that the scan they advised me to do it will, you know, maybe will give me the answer of why did I have this delay.
Okay, Emilia, don't worry.
I'm so tense and I'm so stressed, really.
Don't worry, Emilia. We are here to help you. We'll try our best to answer all your question and help you. Now, Emilia, this is my first time to see you, so I just want to know more about you. Is this okay?
Sure.
Okay, Emilia, can I ask you for how long you are trying to get pregnant?
Yeah, it was 1 year mainly since I stopped all the pills I taking for contraception.
Okay, um, and okay, sorry. And what do you have any other problem, Emilia?
No,
Can you
I don't have.
tell me more about this problem, please?
Yeah, actually, I'm trying, and I check my ovulation. I have an application, this one, and I trace my period. It usually comes regular, and I see when is the ovulation time. We do have, a good relationship, me and my partner, and we think that we are doing all the right things, to make it right, but it didn't work. We shouldn't have, this time. I don't know why. I'm fit and healthy. My partner as well. He
Okay.
doesn't smoke. I don't smoke. I exercise. So we eat healthy. We do everything.
Okay. Can you tell me more? When was your last period?
Yeah, it was 10 days ago.
And as you said, is it regular, right?
Yes.
Regular. And for how many days you got bleeding, and how many days bleeding, and how many days between two periods?
Yeah, I got bleeding for 4 days. Okay. And then after exactly 24 days, I got the next period.
Okay, that's good. Do you have any pain with with your period?
Yeah, a little bit. Sometimes I take paracetamol, sometimes I take ibuprofen for it.
Does it start with a period, or and for how long it lasts after you
Sometimes I
start your
start,
period?
yeah,
Hmm.
sometimes I feel like heaviness a little bit in my lower tummy. The few days before my cycle started, and then during the cycle I got some pain. For that I told you to take some paracetamol and ibuprofen, but
Hmm.
it's okay.
Okay, so it's just mild. Okay, any problem? You told me you are in a regular relationship, so
Yes.
any pain during the intercourse?
Mm, Usually it's fine,
Hmm.
unless in some, what I mean, in some position. Um, I feel like, no, I can't do it. Um,
Hmm. Hmm. Okay, we'll try to help you. And any problem in your bowel when you open your bowel?
no, nothing at all.
Nothing. And how's your water work?
It's fine. It's
It's
okay.
fine. No weight gain, weight loss in the recently?
No,
Okay, okay. And can I ask more about your partner? How old is he?
he is 32.
32. Did he father any kids before?
No,
Okay, and his
had a he had a recent test, and the GP told him it's fine.
it's fine, and he's not a smoker, you told me, and he's not overweight, right?
No, no, no. We pose in the average weight.
Okay, okay. And how's your pap smear, Emilia?
It's fine. I did it once and it was okay.
No, any discharge coming from down below?
No, nothing.
Okay. And currently, do you or previously did you use any contraception?
Yeah, I used to have the pills, for the contraception in the last 3 years.
Okay. And you stop it for how long now?
For 1 year.
1 year.
Exactly 1 year and 2 months.
Okay. That's okay. That's good. Okay. Are you fit and well? Do you take any medication for anything?
Yeah, nothing. I take nothing.
Perfect. Any surgery in your tummy or down below?
No,
Yeah. Smoking, alcohol,
no,
and alcohol, no?
no. I don't take alcohol. No.
Okay. Okay. And sorry for my next question. Any drug abuse?
No,
Any allergy for any medication or food?
no,
Any family history you want to discuss it with me regarding ovaries, regarding their fertility, regarding
no,
breast, tummy,
no, nothing. No,
boiling?
nothing at all.
Thank you. And who's supporting you at home?
Um, I'm working, and my partner as well. We both are working in the same company, and
That's great.
it's
So,
fine.
okay. Emilia, do you mind if I examine you before I discuss with you the result?
Yeah, sure.
So one of the nurses is coming as a chaperone. I'll examine you, then we can discuss the result.
It's
Okay.
fine.
Thank you, Emilia. Thank you so much. So As I can see here in the, you have some blood test done and an ultrasound done. So regarding the blood test, there's two markers tested. The first one is CA125. This is a marker, just a blood protein marker, and it's non-specific marker that can raise in many conditions. One of these conditions called um, endometriosis. I'll discuss with you now what's endometriosis. And the ultrasound is, I'll start over, sorry. Okay, Emilia, I am from your investigations and your ultrasound. I can tell you that you have.
You said that there was another test. One of them is the protein something,
Yeah.
and what about the other one?
Yeah, the other one also is another marker, a protein in the blood, which show how your ovary is functioning. It's called AMH, anti-Mullerian hormone. So it looks fine to me. Regarding the ultrasound showed that there is the right and left ovary. You know, we have two ovaries, one right and one left, and both of them there is a cyst um, with collection of blood, one on each side. On the right side, it's 8 centimeter. On the left side is 6 centimeter, and there is blood inside these two cysts. And your right tube, and this is the diagram I can show you now. This is the uterus, and we have two tubes where the sperm meet the ova and the babies form, and we have two ovaries here. So this is the two ovaries, two cysts here, and this is the right tube. Here a small canal or small tube connecting the ovary to the womb, and it showed also collection of blood. So from this all investigation, I can tell you that you have what we call it endometriosis. And endometriosis is a condition which we don't understand till now fully, but mainly it's, you know, this is the womb and this is the lining of the womb. Parts of this lining can migrate through the tubes and go and settle in your pelvis, and settled on the ovaries also. So this is abnormal location of the lining of the womb. That's why you may get some pain with the period. You may get some pain with sex. So
Your time? What's your time?
Thank you.
Okay, thank you. So we will do strictly practice on the 10-minute frame. Okay, and sorry to interrupt you. I'm so sorry, but the thing is that we said again and again, it's my way, if you know it, that if we practice in 10 minutes, and our brain is so smart, you know that, and your brain will be able actually to identify what is the 10-minute time, okay, and then after 3 weeks of actually practicing this way, you will gain this insight, you know, you will get the inner clock, the physiological one, that, okay, this is a 10 minutes, and here I'm now halfway, you know, in my task. Now I passed 2/3 of my task, and so on. Okay, so in the exam, you will always, okay, practice within the time frame, and you will never unfinish a task, you know. The problem with people when they practice in 16 minutes and 18 minutes and 14, 13, that every time they send, you know, some different signals, you know, to their brain, and then your brain become confused by what time frame, you know. So this is the problem actually. That's why those people in the exam, they will have a lot to say, okay, but unfortunately the bell will ring before they finish. Okay, I'm sorry that we have to stick to the 10 minutes.
Yes.
It's simple. It seems first that it's like unfair, or it will give you that sensation of, oh my God, okay, time passed, I fly away and I didn't finish. But it's for your benefit, believe me. Okay, and by the way, this is evidence-based. Okay, that every time you should do it. Okay, in the same time. So thank you very much for your, volunteer of this task. You were a good doctor, I believe. Okay, so I would love to have such a doctor like you in my clinic.
Thank
but,
you.
Yeah, let me give you my feedback.
Yeah.
Okay, and the feedback first that I would like to share with you is you have a calm voice. Okay.
Mm-hmm.
You are not so stressed when you speak to your patient, and you are confident and calm. This is a very good point in you. Okay, this is a strength point. Another thing, your English is good. Okay, and you are comfortable and fluent when you speak to the patient, which is another one good. You don't use jargons. Okay, so it's a good thing as well. So mashallah, you have strengths, in your practice. You also able, to have a two-way conversation between you and the patient. Okay, so it's not like one-way conversation. It's not like a dialogue. Okay, it's good that you have, the two-way conversation. You listen to the patient and you reply and so on. So it's a very good point of you as well. Okay, that good start. Okay, will give you a good impression in the exam. You have a friendly start with the patient. You also started with the present complaint, which is good. Okay, and you finished your history, and then you went to the examination, and then the explanation, which is, the chronological and the logical way of approaching a task or the consultation. All of these are good points from you. You thanked your patient. I was happy you did that after you finished your history, okay, for the information that she shared with you. You also had her permission for the examination. It's all fine, okay? So asking the patient for permission, you also thanking the patient. All of these are good points in you, okay? So please keep on doing this. I will come to the point of, that require improvement in your practice. And please, be with me. And I don't mean to be tough, but this is for yourself. Okay, I can see that you tried to complete your history. Okay, but you did that. You had a good history as well. And I can say it's even extensive history. Okay, you asked about many things. You asked even about things that been told before. Okay, so just we are repeating ourselves. But you finished your history in 7 minutes. Okay, which is a very common and big problem, when we practice in the exam. And I believe that all my friends, in the previous patches, they know that, oh my God, every time Dr. Rawa is giving us, the feedback of this point, yes, and I will never, give up saying that. If you have a task, and let's say your task is out of 10 mark, okay? So you have 10 minutes and you have 10 marks for the task. Do you know what are the domains to be tested? Patient
Yes, we know.
safety,
Yeah.
communication with patient, communication with colleague, information gathering, and applied clinical knowledge, right? Right? Okay, so when you take when you take history from the patient, this is under the information, right? But I would like to say also that information gathering does not only have the part of taking history, right? So if I have been tested in 5 domains and with a little bit of, basic mathematics, then each domain should have what? Should have 2 marks, right? And if I have 2 minutes, then that's mean each domain will have how much? Each domain will have almost 2 minutes, right? Okay, is it possible to take history in 2 minutes? Usually not. But what we will do is, Because also when you take history and you introduce yourself to the patient, you make the patient feel calm and she's comfortable to speak up with you, you are doing a communication with the patient. And when you ask about certain points, you are also covering some important safety point from this condition. So I would say give the history taking 1/3 of your consultation. That's mean 3 minutes point something. Let's be generous and say 3 to 4 minutes maximum. Please don't ever exceed 4 minutes for the history taking. Whatever the history taking is, don't exceed the 1/3 of your station. Your maximum limit is 4 minutes, okay? Why? Because simply you need time for the explanation, right, of the condition, and you need time, okay, to offer a management plan, right? So whenever we have a report, whenever we have a task with the reports, how would we utilize the time in this task, okay? Or sometimes not a report, sometimes with a condition, with a diagnosis, and you want to explain it to the patient. 1/3 of your time should be aiming for what? For the introduction and history taking, right? This is the 1/3, the first third. Second third is for what? Second third is for explanation of a report, right? Or explanation of the condition, right? This is the second third. Third thing that you need to offer a management plan and finish your station, right? So you spend the 10 minutes and you stopped within which part, my dear?
Second part, and even I didn't complete it.
You didn't complete the second part, right? So you stopped here. So even you are a good doctor, okay, and you're speaking well to the patient and you have a good communication, right? How many marks do you think you can gain in this?
Just
in this
3 or 4 maximum.
Yes. Okay. And if you have been marked for pass or fail or borderline, what do you think you would take?
F, big F.
Yes. I'm sorry to say that, but it's yes. It's not even borderline because the aim of that task did not complete. The patient didn't get any benefit from the time she spent with you, right?
Right.
So please, my dear, time management is a key of success. Without time management, you will not be able to go to the second part. You will not be able to go to the third part. You will not be able to pass any station, right? So time management is very important. People in their starting point in the preparation, they will be, unfortunately, under the stress of, I want to complete the history, okay? And I would say that, I'm sorry to say that, I don't want to criticize anybody, but I'm sorry to say that it's came from the telegram in the first, in the first thing. How? I'll tell you. A candidate volunteer, what happened is, a candidate volunteer for a presenting a task, okay? The candidate is a very good doctor, okay? And she was able to take a quick history and then explaining to the patient, asking the patient about her concerns, answered the patient concern and questions. She offered a good management plan and finished the task in 10 minutes. What the feedback that she will receive from the telegram? And I wouldn't name anybody because actually it doesn't matter, okay? But it's something that I have seen really and experienced myself. What feedback she will receive? I'll tell you what the feedback that she will receive. You didn't ask about her occupation. You didn't ask about how things are at home. You didn't ask about the family history of endometriosis. You didn't ask about the any sexually shared infection, right? You missed the smear, you missed this, you missed that, right? So you become automatically, you know, next time you want to be overprotective. You want to complete the task, okay? So I can see the candidate at the first part of their preparation, if of any course, either it's an intensive course or a long course, they are keen, you know, to complete the history over anything else in the task. And this is the problem, okay? So guys, don't think that you are just, you know, less expert than anybody who passed the exam. No, you are very good and you can pass this exam. And don't blame yourself. It's a misconcept. So simply, let's break these misconceptions together. Okay, I want to take a history. What is the important thing here in this station about the history? First thing in any history in the world is the current complaint. And avoid asking the same questions again. So if the patient said that my current complaint that I'm trying for a pregnancy in 1 year and I don't know what happened, I'm fit and healthy and my period is regular, the patient helped with so many things, right? And we don't know why I follow everything. So don't please repeat the questions again. Focus on the history of the endometriosis because it's there, right? So asking about the endometriosis symptoms is very important in this case, right? So it's basically a gynecological history. It's not a fertility history in the you know, in the current in the detailed form of fertility history. Okay, just do a quick questions about the condition, about the manifestation that she have, the symptoms that she have, you know, for the endometriosis. It was good that you asked her about the pain during cycle. Okay, however, you repeated the question, but no problem. It's just a practice and you will improve next time, I'm sure. And you asked about the problem during the relationship or the pain during the relationship or during intercourse. Okay, we can ask also about the chronic pain in the pelvis. I think you covered by asking if this is related to the cycle or anytime else. Okay, you asked about the discharge, which is good, okay, and you asked about even the contraception. And you ask it quickly about the medical history, surgical history, allergy, social, okay, and the STI, okay? So you covered the information gathering part, okay? But as I told you, it's the mainly, you spend 7 minutes, okay, in that task. So in the discussion, you should have completed your report, okay, when you explain to the patient, explaining what is the CA 125, what is the AMH, okay? So short explanation is needed, okay? So you can use, you know, some layman terms, okay? So we can refer to the ovary like the egg basket, okay? The producing egg that doing fine, okay? The particular protein in blood raised, okay, which can be explain in correction to your scan reports, okay? So we don't need to speak much about the possibility of the raised CA 125, okay? However you did, it's okay, but I believe that you needed more time for the you know, for continuation of the station. This is the only deficiency that you have, okay? Otherwise, you did well, okay? You avoid the jargons. I have comments from your friends here. One comment that asking about is really the examination is needed in this case. So what do you think? What would you say for that, Medea?
I think, yeah, it's very important to examine the patient.
Okay, so I would advise you to do what you believe is right, okay? How, my friend? So my friend, Dr. Jane, answering your question about the examination, especially if the reports are there, is it important or not? I would say that whenever the examination give you information about the task, about the case, okay, the presentation of the case, okay, this would be useful, okay? So if you feel that I want to invite the patient for examination okay? And I would gain more information by examining her, okay? Nobody's going to blame you in the exam, believe me. Okay, so it's up to you. You are a doctor still, and there is, you know, a place of do whatever you think it's correct to gain the information. Okay, so some doctors would say that examination in this case is going to provide me with, you know, feeling of her tummy, her ovaries, the enlarged mass, okay, and gaining information, especially because we are going to speak about surgery and about management, right? This is one thing. So I believe if I were in the same, okay, I would even ask her to do an examination, at least an abdominal examination, okay, to have a look to her tummy, because we are going to speak about surgery afterwards. Is it something that if you leave it, we will fail? Okay, no. Another question is, ask to explain report and discuss management plan, then ask to take history or examination. Still need to do it according to the domain. Yes, Dr. Sarah, I'll tell you, my dear. It's very important to obtain history, okay, from the patient regarding the, you know, the current situation, right? It's very important. And I would comment on that maybe with the next task. When you have obtain a brief history, okay? This is a very clear advice to take a history, right? But sometimes he didn't write obtain history, correct? Which is good. He didn't write obtain history, but he writes explain report only and management plan. Let's say that, okay, in a properly written task. Information gathering, however, is there in the testing domains, right? Okay, so how can I manage to obtain information, okay? And what about the history? Shall I take all the history or shall I take the related history? I must take a related history in all cases. A short, quick history if the you know, obtain history is not even there. Why? Because it's make a logic, okay? When you come to discuss with the patient about the condition, about her manifestation, or about the planning, okay? And you asked her some questions in the beginning, and the most important part is the current complaint and the concerns, what is her own concern and what is her own manifestation, right? So if you need to know that before offering a safe management plan for the patient. But shall I go to ask detailed history? In this case, no. I don't need to ask detailed history. I will make it short and quick, right? So in every task, my friends, you have a role player. At least know what is happening by asking about the current complaint and anything related to this current complaint. Understand the situation. Ask the patient about her concerns of the today's discussion. This is the most important thing. This is baseline to any consultation. Let's imagine I have a consultation, okay, where only written to me in the exam, discuss report and offer management plan, okay? Can I say, hello, is it Sarah Jones, for example? Would you please confirm your date of birth for me? Here, I'm your doctor today, and I have the reports. Let's discuss it. Can we do that? No, we can't. What we will do is simply, okay, we're going to introduce ourselves. We would like to know why Sarah's here today, right? This is very important. What is her main complaint? This is another thing, okay? We ask some safety question to ensure that we have the right diagnosis. Yes, We ask about hair concerns. Yes. So in this case, I would say that we will shrink the history, taking and make it only specific to the current complaint and patient concern. Okay? This is the most important thing in that task. Okay, guys? Okay, so in the discussion with our patient here, okay, so the patient have a problem which is related to the fertility, and she do have 2 blood reports and she had a scan, right? Okay, we will need to explain to her the blood reports and the scan, and we need to explain to her what is the endometriosis, right? The endometriosis is a chronic condition that result when the tissue, okay, that's similar to the lining of the womb, gets deposited outside or seeding, or sometimes they use migrating outside the womb in other area in the pelvis, in the ovaries tube, which can cause pain during menstruation, also decrease the egg reserve in the egg basket. Right, so the scan show the cyst or the blood-filled sac, okay, or the endometriosis in both ovary, which are of significant size. The significant size is very important because if the patient had endometrioma like 1 to 2 cm, for example, okay, then we can discuss with her, okay, whether we go for the treatment or whether we do the surgery as per the, the advice, and we discuss about how does this affect the reserve, the ovarian reserve, and we will let the patient take her, decision. But when it is a significant size, the patient need to understand now that we need to go for what? Surgical management or conservative management, or go to IVF immediately. Yes, I'm just waiting for your questions, guys, my friend. Do I need to explain endometriosis? Yes, I need to explain endometriosis. Right? Why do I need to explain endometriosis?
I mean to ask Dr. Abba, like endometriotic cyst, after the discussion of the endometriosis, do we need to explain what is a cyst of the, I mean to say collection of the blood?
It's a collection of the blood, okay, that comes from where? It comes from the
Lining of the womb.
tissue,
Mm.
outside the womb, okay, and it seeds in which place? It seeds in the ovary, okay, and it causes a blood-filled sacs. That's it.
Okay.
Why we need to explain the endometriosis, okay? It's written there, my friends. It's written that bilateral endometrioma. Okay, so shall I discuss other possible causes of endometrioma? No, if I have a cyst, only cyst with raised CA125, I would explain the possible causes of raised CA125, right? But if he writes for me and he makes my life easy in the exam, okay, that this is endometrioma, simply, okay, he helped me so much today, right? So I will follow what is being asked, okay? Now, explain the report for this patient, explain the endometrioma, okay? Differential diagnosis is needed in this case. If he writes clearly the diagnosis, no, we should trust the examiner, right? So I will simply explain what is written to me today. Clear, my friend?
Dr. Abba, if the clear diagnosis is given there, should we ask about the sexually transmitted infection, vaginal discharge? Because already we know the cause of her symptoms.
Yes, you know the cause of her symptoms, okay, since it's written there, okay? But we would like to ask about the manifestation of endometriosis. You know what is the important symptoms that I would like to ask about in the endometriosis?
Less painful periods and painful sex and any bowel bladder problems she is having at the time of the periods. And
yes, excellent, excellent. Okay, so those are the most important thing. Okay, the cycle first, right, Dr. Rika?
Yes.
And
Yes.
then asking about the pain, right? Pain during the relationship or the painful sexual intercourse, right? And asking about the symptoms of urinary endometriosis, right? If she had any problem with the waterwork, I can even make it specific passage of blood, but it would be, you know, more scary to the patient. So just ask, it's fine. If there's any change in the bowel habit or in the waterwork for this patient, it's fine. Okay, so those are the most important thing to ask about. Okay, sometimes when the patient have a pelvic mass in the size of 6 and 8, they will have congestion and they will have a chronic pelvic pain and discharge. Okay, so it's a secondary one. It's a secondary problem to ask about.
Okay, so
That's
we need
why,
to ask,
you know,
like, one question regarding this.
Yes, you know, my friends, in the exam, you will have, for example, 10 points under the information gathering, for example. Okay, so information gathering, there are 10 points written there. You might find 3 or 4 points with asterisk on them in the model answer of the college, you know? So this is very important point that if you miss one of these, okay, it's going to affect your mark. And if you miss 2 of these in the part of, for example, or in the domain of the information gathering, you are going to be marked as failed in the information gathering in this case. Right? So the most important thing is to ask about them in the exam are the point of the asterisk. So how would I know which point have an asterisk in the model answer or not? Anything that you can't afford to miss, right? Like what? Again, can I ask about a case, a thick history from a case of endometrioma without asking about painful period? No, it doesn't make any sense. Can I ask about endometrioma without asking about painful intercourse? No. Manifestation of endometriosis in any place else, like for example, affecting bowel, patient might have blood in the stool. No, I can't afford to miss this part, right? Dr. Sarika is asking that I don't need here to discuss the differential diagnosis of raised CA125. If I have a clear reason of raised CA125, do I need to go to discuss other possible causes of raised CA125? No. But in another recall, okay, which is I think the 18 years old girl that have raised CA125 with a cyst, an ovarian cyst. It was written there, only cyst, right? For this girl, I need to discuss possible causes of raised CA125. Is that correct? Why? Because he only tell me that this is a cyst in the exam, right? And I need to take history of endometriosis, of course, and I need to take history of ovarian cancer symptoms and family history for the girl, for the 18 years ago girl. Okay, so whenever guys he tried to help you in yourself, okay, trust the examiner and simply follow the leads given in the question, right? Don't make it hard on yourself. You will not find time to cover all. Clear, my friends? Okay, yeah, so good. Okay, so how about the management? Please tell me, guys, what do you think about the management? And here I would like to ask Dr. Amira's opinion because she is the one who presented the task and I would like her to continue the consultation. Dr. Amira, dear, what would you advise for the management of this case?
So I would advise a surgery to remove these 2 cysts, and it's better to be like keyhole surgery, laparoscopic or bilateral ovarian cystectomy. That's my plan, and also I will go through the risk of removing the risk of laparoscopy. Also, I'll explain to her all the advantage and disadvantage of laparoscopy.
Yes, okay. So you advise the surgery. Surgery, of course, is the correct answer for this size of the cyst, right? What are the main problem of the surgery? If I want to explain surgery to this patient, please tell me.
So
I'm your patient now, and you want to tell me what are the side effects of the surgery. Please start with the common side effect of the surgery, right? It's a general surgery, right? General side effects. Then go to the specific effect of surgery, okay, on the ovarian reserve. Give me alternative, and it will be my decision, please, okay, to take the decision of surgery or not, because you have to give alternative even if you believe that this is the correct management, okay? So in the part 3, we usually give the patient alternative, starting from doing nothing, right? Or going, for example, to the fertility center, right? Right away, or surgery, right? How does this make sense? Yes, this is the thing about the counseling, that the patient had the right to choose, even if she had the right to choose doing nothing. Some patient, and in real life, you think about it, okay? It will make sense. In real life, I'm a fit, healthy, okay? I'm exercising every day. I only have some mild dysmenorrhea, and I take ibuprofen or paracetamol of it, and it's going fine. I have no major problem in my sixth life. Okay. So why would I go for a big surgery, a keyhole surgery, removing 2 big sacs and, you know, affecting my ovarian reserve? It can cause problems to me and side effects. Maybe I would be too scared, and I would say, no, I don't want to do that. Right? Right. It's the patient right. So please, in your counseling, offer me options. And this is a key in the part 3, by the way, that you always offer options, including the option of doing nothing. Okay? So it's not only one answer that fits for all patients.
Okay. Now, Emilia, coming to the management of this situation, so I would recommend to have a surgery which we call it keyhole surgery. It's a hole you will be asleep, and we will do a hole in just below your belly button, and we will go through by telescope inside your tummy, and we'll try to remove these 2 cysts. And of course, if there is any tissue of this endometriosis in your pelvis, we will destroy it, we will burn it. This surgery carries some complication, as you know. Every procedure can carry complication. Complication of anesthesia could be there. Risk of failure of entry by this telescope through your bottom belly, and also injury of any internal structure, heavy bleeding, and also there is a risk of if the cyst is too much destroying your ovary, extensively destroying your ovary, there is risk also of removing your ovaries. This is one of the options. Are you okay with this, Emilia?
Yes, Dr. Rat, it's fine. It's fine for me. Okay. Yeah,
so,
I think. Yeah, I think I need to think about it. Yes, because you told me that this is going to affect my egg production. Okay, so it might affect my future. You know, I think I need to know more information about that. How can I get more information?
Okay, Amelia, no problem. You can take your time thinking about this procedure. I'll give you a patient information leaflet here. and I can show you some websites. You can read more about this procedure and the endometriosis, and I can arrange another appointment for you and your partner with my consultant. Then you can have a further discussion about this procedure and further plan. Is this okay?
Yeah, doctor, it's fine.
Thank you, Emilia, for this conversation today. Do you have any other question to me I can help you?
Yes, doctor, please. I have my friends who had, a test tube baby. So can I have a test tube baby directly?
Yeah, if you are not happy to go further with this procedure, you can, if you want to try further, try having baby without any intervention is one of the options. But also you can, if you need to do like self-referral to any tube IVF center, you can do that. One of the option also is available. But I think I'm not working to NHS, but I think that would be not be funded by NHS.
Okay. Okay, thank you.
Thank you.
Okay. Thank you very much. Okay. So thank you. So may I ask you a last question, my dear? And God bless you. I can see that you have a cough. And wish you speedy recovery. Do you think that after the treatment of the endometrioma, if the patient is not still having, successful pregnancy, what is the management?
Say that again, doctor, again, please.
If the patient had the treatment already that you suggested, which is the surgery, okay, and then after that, still your patient have a problem, okay, so what you will advise?
I'll advise to go for IVF center for trial.
Okay, after how many?
6 months.
Yes, exactly. Thank you very much.
Thank you.
Okay, thank you. Any questions so far, my friends?
Dr. Rabaa, if the patient didn't ask about the alternatives, should I offer it myself from the start or just wait for the patient?
Yes, it's a good practice that you offer the patient alternatives. It's a must. Look, my dear, if you read any of the patient information leaflet or you went to the NHS website, okay, and you search any condition, okay, let's say it's a patient who's high risk with Down syndrome, a patient who is having even cancer, right? A patient who have been tested for BRCA gene and found to be positive, okay? We always give them options, right? A patient who had in the stage cancer, do you think that this patient have, or advanced cancer, I would not say in the stage, advanced cancer, stage 3 cancer, okay? And the patient will go through chemotherapy, for example, neoadjuvant chemotherapy, then she will have a surgery, and then after that she will have adjuvant therapy, for example. Okay, do you think that this patient had the right to choose to do nothing or not?
Yes, she has the right to do nothing.
Yes, of course. So whenever you have any condition, it's not a best answer. It's not a part 2 exam question when he asks you what is the best answer or what is the appropriate management or what is the best management, right, for this case. And you take, for example, neoadjuvant chemotherapy plus surgery plus adjuvant therapy. No. In the part 3, you are facing a real case or a real person, right? Even if she is a role player, no problem. We are dealing in life with human beings, and human beings, they have different opinion regarding their care, right? And if they have the autonomy, okay, and they are sensible adults, then they would choose for themselves, right? If the patient said no treatment, okay, so what you will advise? First of all, it's her right. So we need to understand that this is her right for no treatment. This is one thing. Another thing is that to make any decision for the patient as valid and informed decision, right? We need to give the patient all the appropriate information. For example, the patient have a surgery. I need to give her, first of all, what is the benefit of surgery? Secondly, what is the surgery, right? What are the side effects and complications of this surgery? What are the alternatives to this surgery? So when you offer all of this on the table for the patient and the patient pick one, okay, she picked when you're offering the alternative, she picked one option, right? She is responsible for her choice now. Is that correct? Let's say that things didn't go well for this patient. She faced the complication. She had a very nasty infection from the hospital. She had organ injury, whatever, right? Who is responsible now for the complication? Is it you or the patient who chose? What do you think, guys? Who is now responsible, legally responsible?
It's me, because I didn't offer her the alternatives.
So
she doesn't know about the alternative.
yes, so it's a must that you tell her alternatives. So when the patient pick a choice among the alternatives you offered her, okay, this will be her decision. She will be responsible for the decision. If things didn't go well, okay, then the patient had nobody to blame because she was well informed and she chose, right? That's why it's a very important principle in the UK and by the GMC that you have a proper counseling with the patient, overhear all the information, including the serious, even if it's rare one, okay, and let her choose, right? If you advised one treatment for the patient and the patient had just this treatment, which is the surgery, because you are the doctor and you know better, you studied, right? You read the guideline, you've read the talk article, and you are confident to offer her surgery only, right? If you did that and the patient had a complication and then she came to sue you or sue the hospital, you are doing like what? Which condition that's very famous? Which case is very famous? When the doctor advised the patient one option of treatment and things didn't go well, and after that the patient went to the court.
Shoulder dystocia.
Yeah, the Montgomery case. Yes, the Montgomery case, right? So don't offer the patient one treatment only for any case. You just offer her alternative and let her choose. This is a very important principle, right? That I offer alternative. Offer alternative, it's make it a habit, okay? Of you have the right to choose not to do anything and just wait. This is one thing, right? But in this case, what will happen? Okay. In this case, the size of the cyst, okay, the blood-filled cyst can increase, it can grow up, okay, and it can twist around its pedicle, okay, and it can cause an emergency, okay, we call it ovarian torsion, or it might burst into your tummy, okay, and in this case, okay, it's another emergency, right, that will need an open surgery to do it, right? It can also continue affecting your fertility and you will not be able to be a mother, right? So I give her the option and I told her the consequences of this decision or this option, right? Another thing is to receive a medication, okay, or a hormonal treatment that will stop the ovary from working, right, or from releasing hormones. In this case, what will happen to those tissue? It can shrink, right? Because you will not be able to have a period. But this is, again, okay, is not going to help you achieve your goal of being a mother at the moment. And on the long term, it can affect your bone, and it can affect your bone health, okay, and your heart health as well, right? So this is one option, right? Third option of endometriosis is when the endometriosis is that size, is to go for surgery, right? And this surgery is to remove, right, the both cyst, right? But because it's a surgery, this is not coming without a complication or risk, okay? Some of the complication that it will cause pain, right? Sometimes it can cause infection after the surgery. It can cause injury to nearby organs, right? And the most important thing that it might come again in the future, right? Because it has a risk of recurrence. In regards to affect your fertility or your egg production, okay, because it's a huge cyst, okay, so it can affect your ovary. Sometimes it's not possible, okay, to take the cyst alone, okay, without part of the tissue of the ovary. So it's going to affect the ability, right, of the egg production, right? Okay, so there will be also some of scar tissue surrounding, which makes the surgery tricky, right? Okay, so you are telling her this, but it's the recommended management, right? Or this is a suggested management by the evidence at the moment, right? After that, we give you a chance, you know, for natural conception, and you need to have this a follow-up appointment with the fertility specialist, right? And after 6 months, if still you didn't achieve spontaneous pregnancy, okay, we might discuss with you the option of having a test tube baby, right? Then she asks you the tricky question about, my friend, she had a test tube baby, why not going to the test tube baby from the beginning? What you will say?
Retrieval of follicles will be difficult, and also there is a tube is affected, so it will going to release the toxins, and it can affect the chances of fertility and implantation of the egg.
Yes, good. Okay, so if the tubes are affected, okay, so the toxins may flow back and it cause harm to the implanting embryo, okay, or even after test tube baby, right? So the option now comes with the surgery, right? So now we prefer to do the surgery to remove the cyst, okay, and preserve the ovarian tissue, right?
Sorry.
How about, yes?
Dr. Rabba, should we say about that cysts are quite big, maybe sometimes unable to remove the cyst only may end up with the oval of the cyst? Oh, ovary, sorry. Oophorectomy.
Sorry, it may end up with what, sorry?
Oophorectomy. I mean to say removal of ovary.
Yes, sometimes it's not possible, of course, okay? So what you will do, okay, you need to tell her this, because the effect of the surgery on the ovarian reserve and ovarian tissue is a main side effect, okay, that we need to tell her. So sometimes, okay, when we remove the cyst, it's not possible to remove it without part of the tissue of the ovary. Sometimes it can be, especially if the complication or if there is a scar tissue surrounding, sometimes it can be very tricky, okay, to remove the cyst without removing the ovary itself, right?
After the surgery, we wait for the 6 months, then we give her the option of IVF.
Yes, Because
If
we give her, we give her
conceive
time,
after the surgery, so
right? I'll tell you why.
I mean to
she's
say, Dr.
definitely
Raba, if immediately after surgery she want to conceive, we will not allow her.
No, it's not allowing her. It's we give her time for natural trial. It's not about allowing her or not.
Okay.
Okay? It just
Okay.
you give her some time.
Okay, I understand you.
Okay, dear. Okay, so is that clear, guys? So we offer alternatives, okay? Why not the IVF directly? Okay, what are the problems with the surgery? It's very important, okay? It may increase the scar tissue inside the tummy, so the surgery might be difficult and damage the surrounding structure, like the water bag or the bowel, okay? Can get injured and require a repair. During the procedure, there may also loss of the some normal tissue of the ovary, okay, which will affect the ability to produce eggs in the future. The success of trying for normal conception will depend on the nature of affection and the scar tissue inside the tummy made by the endometriosis. Okay, there might be also a need for assisted reproductive technique, either test tube baby or ICSI, okay, or directly injecting a single sperm from the partner into the egg. This is how you explain about the ICSI. Okay, my friends.
Ma'am, when we are giving the options like doing nothing or medical or surgical treatment, we will say to the patient what you prefer, then we explain that option only, or should we say that no, if you not go ahead with the treatment, no treatment, then these will be the consequences.
Okay, I can say a short statement about each one of them. Okay, so you have option starting from doing nothing, but in this case, okay, we can't guarantee that the problem is not going to exaggerate and might cause a severe injury to you in the future. Okay, I can go also to the option of the test tube baby, but if I went to the test tube baby directly, okay, so might be release toxins, okay, that comes from the tubes, okay, and it affected the implanted baby, or even after you had the test tube baby, it can continue on releasing the toxins and can be very dangerous and affect your success rate. Or I can advise you of having the surgery, okay, but in this surgery, we will advise to remove both cysts, okay, through a keyhole surgery, or sometimes it can be tricky and we need to turn it up into an open surgery. And during the surgery, we are going to remove both sacs or both cysts from the ovaries. And the problem or the challenges that we can face is that there will be scar tissue surrounding, okay? And this might increase your chances of having a complication during surgery. Those complications is still uncommon, but it can happen, so you must be aware of it. You might have injury to nearby structure, or sometimes you can have some bleeding, and in this case, we require a repair. Okay, sometimes also when we remove the cyst, okay, it is inevitable that we take some normal tissue of the ovaries, and this is going to affect your ability to produce egg in the future. Okay, so another alternative also to the surgery is that we do a drain to the fluid inside the sac, but it is associated with a recurrence, okay, a high rate of a recurrence in the future. So this is, you are giving her options, okay? Today, you don't need to reach to an agreement of what should be done, right? It's a big decision to take, to be honest, okay? So what you will do is you are going to consult with your consultant, refer her to the fertility clinic. It's very important, right? Okay, you might even arrange further imaging, okay, to know more about the type or the nature of the cyst, okay, like arranging an MRI or something. Offer her patient information leaflet about the endometriosis, right? And write back to her doctor. Is that okay?
Thank you so much, Doctor.
You are welcome, Maria. So, guys, the aim of the consultation, again, is not to reach to a definite decision of the surgery today. The aim of the consultation is to give information about the endometriosis, about what are the available options for the patient, okay, and about the pros and cons as much as you can of that surgery, which is the main thing that you need to discuss with her. Most important thing in the communication with colleague, that you discuss this with your consultant and refer her to the fertility clinic. Offer her a written information. That's very important, because the patient will go home. Imagine that she will go home, discuss with her partner about the condition. She doesn't know many of the information about the endometriosis, so she will start random search, right? And she might find some incorrect information on the internet. So it's not safe. It's best that you offer her a patient information leaflet from your side, right? Correct, my friends?
Yes, ma'am.
Right.
Okay, so this is what you will do, my friend. And this is, again, I don't know actually if you have another plan to manage this patient or to offer her a different management option, but I would say that those are the principles of consultation for any case, and take it as a rule, okay? If you have a patient with endometrioma, if you have a patient, for example, that she have fibroid, okay, and she want to conceive, same principles, right? Offer the patient different options, okay? Go quickly to the pros and cons, and then what you will do? You
Leave
let
the
the
patient
choose.
to, yeah.
Yes, let the patient choose. It's very important. This is what's called autonomy, right? Okay, so my friends, let's move to the next task.
Dr. Rabah, I've got a question to ask.
Yes, please.
I
Go ahead.
understand that we will give like 6 months after the surgery, so that patient may get the chance to conceive naturally. However, I think there's no any disadvantages. We refer them early to a fertility specialist or IVF specialist. So can I say that meanwhile, when we are waiting for you to naturally get pregnant, I'll just refer you to a fertility specialist or IVF specialist, so that they can do some investigation first for your partner, and to get you prepared for IVF. Can I say so? Or do I
Look,
need to
my dear,
really wait for 6
yes, the
weeks?
referral. Okay, so the referral, my dear, from now, I can start my referral or not? What do you?
Well, I mean, right now, she hasn't do the surgery, so it's too early. But I'll just say that
arrange
I'll
a
refer.
referral. You can arrange the referral from now. Okay, she might be seen once. Okay, with to you know, she will have a meeting with her, the fertility consultant, and he will better, you know, counsel her about the fertility options that she might have. Okay, she will be registered as a case with the fertility clinic, right? And they will follow her up after even her surgery, right? So she will benefit from a referral to a consultant, okay? And the best consultant or the best subspecialty that you will refer, it will be the fertility consultant. That's it. Okay. So you don't need to refer her now to the fertility center. You need to refer her to the fertility clinic.
But I'm not now in the fertility clinic, so it's different, is it? Different kind of fertility clinic, right?
Okay, so if you are now in the fertility clinic, okay, that's good. So you will just arrange another appointment with your consultant.
Okay.
With the fertility consultant, right?
Yep. So in conclusion, there's no wrong to say that in my management, I'll refer you to a fertility consultant, my consultant.
Yes. There is no, there is nothing wrong in that. Okay.
So not necessary to give a timeline like after your surgery, then only I will refer. I'll just like
it's not only after surgery, my dear. What you will do is you will discuss the option of IVF if she did not, or we will offer her the option of IVF if she did not conceive spontaneously or naturally after the surgery by 6 months. That's it. Okay, so IVF will not be offered now for the patient. IVF will be offered after she had a surgery and she didn't still have a natural pregnancy. Right?
Yeah, okay.
And to be honest, do you think that the patient, once she is on the referred to the fertility center, she will get IVF directly? Waiting
No,
list
yeah, that's why
too long.
I was thinking like we will do it earlier, the referral, and then
Yes, you
we'll
will
see
take the
later.
referral. Yes, you will do the referral. Exactly. You will do the referral. Okay. And then she will take her time in the waiting list. So don't worry.
Okay.
Okay. But you are just referring the patient to the right subspecialty to diagnose her. So you will now saying to the examiner, okay, that I know that this is a case that is above my level, right? And this case should be managed by this subspecialty, okay? So you are safe, okay? And the examiner need to hear that. It's very basic things, but believe me, people forget it in the exam and they lose mark in the communication with colleague, right? So people comes out from the exam and they have, substandard level in communication with colleague because they didn't offer the routine referrals. Okay. So you think it's a routine thing and it's something that I don't need to say, but unfortunately, it's not that much as you think it's routine. No, it's something that you need to say to you take the mark. If you didn't say it, you will not take the mark simply, right?
Okay. So Dr. Robert, I just have a question. Like when we prepare for each station, do we need to really like figure out that station? What is the asterisk point in each domain? How do we prepare it? Like for this station, when I prepare, how can I prepare wisely? Like do I need to think of like for this station, what is the patient safety point? Do I go by this way?
Look,
This kind of preparation.
It's a good question. Okay, so I will tell you something, okay, about how to approach the station. If you are preparing for a station, okay, and let's say you want to read the topic, okay, either this station or another station, for example, endometrioma in pregnancy, let's say, or endometriosis in pregnancy. There is one case, a patient that had endometriosis and she is coming for reconception counseling, right?
Yeah.
Okay, so how I'm going to approach this case, right? I know that there is a recent article about the endometriosis and the obstetric outcome, right? Let's say that this is how I prepare things, right? Okay, so I would first go, okay, let me just show you, my friends, what I will do. First of all, I will decide my source, right? Source now is defined as the TUG article. There was a one TUG article about the endometriosis and obstetric outcome. Okay, so I read the TUG, right? Then I covered how many? Do you think how many points of the total mark I covered now? I covered around 20 to 30% of the mark, not more than this. Why? Because applied clinical knowledge, my friends, applied clinical knowledge is one domain that's been tested. You will have the case in the exam either with 4 domains or 5 domains. Rarely it comes with 3 domain tested, right? So means that I covered now the applied knowledge. Is that correct? So by reading the source, I covered applied knowledge only. Do you agree?
Yeah.
Yes. Okay. Then I will go to open a website, okay, of the patient information leaflet of endometriosis, right? So patient information leaflet is very important in my preparation. Why? Because if this is a simulated patient task, that's mean I need to be familiar with the late term language to speak to the patient, how to explain to her, for example, what is a CA125, what kind of the blood test that it had a protein being tested or a marker being tested, okay, that produced from the cells, okay? And it can be for many causes and so on. Or how can I speak about cyst? Is it a fluid-filled sac, or it is a blood-filled sac, like in the cases of endometrioma, and so on, right? So I need to be familiar with the patient information leaflet to avoid jargon in the exam, right? And believe me, this is very important because part of your counseling, if you remember the first part, second part, and the third part, PIL is going to help you so much in which part? In the 2 and 3, right? Especially 2, when you explain the condition to the patient, right? And sometimes 3 in the management and offering management options. So going through the patient information leaflet of the same topic is going to help me, right? Right? So
Yeah,
it helped me
yes.
by how many? I would say at least 30%, believe me. Okay? So I now have TUG article, patient information leaflet. Okay, what is the rest? The rest of 40 to 50% of the station. This is your skills in running a consultation, right? How would you start your consultation correctly, right? From the intro to the patient. How are you going to make the patient comfortable and break the ice at the beginning? How concise is your history taking, right? And in your explanation and the time management, did you follow the same 3 parts technique that we said about it? Okay, so you will take the third part for the explanation. In your management option, which is a very important thing here, did you offer the patient options or choices and respect her decision? Did you listen to the patient and answer her concerns specifically, or you just speak, okay, uninterrupted? So almost the half of the station is your technique, right? So having a good technique can be very important. Having a good technique is more important than the TUG article or not? Yes, it's even more important about the study, more important than studying TUG article or guideline or whatever source, right? Patient information leaflet is mandatory for the part 3 because it will teach you how to counsel a patient. And you know what? If you open a patient information leaflet, okay, you will find that the principle of counseling are there. Okay, how? In any patient information leaflet you open, what you will find, what you will see in any patient information leaflet. 100% you will see that they offer the patient the explanation about the condition, right? And they offer options of management. Is that correct? Right? Right?
Yes.
If you follow any patient information leaflet, let's open any patient information leaflet, a random one, okay? And you will find that all the principles of counseling are there, right?
Yeah. Yes.
Hello, Dr. Reka?
Hello.
Yes, ma'am. Hello, my voice is clear, ma'am?
Yes, it is. Please take your 2 minutes in reading.
Yes.
Hello, dear. Are you ready?
Yes, ma'am.
Okay. Shall I start your timer now?
Okay.
Okay. I believe you do
Hello.
that. Okay, please start.
Hello, I'm Rekha, one of the exam candidate. I go through the instructions. I'm ready for structured discussion. So,
as you can see here, our patient who is 34 weeks in her pregnancy, she had anti-C positive. So may I ask you, what is the risk of having the anti-C positive in the pregnancy, and how are you going to manage this case?
Yes, I have the case of the 34 weeks with the anti-C antibodies. First of all, I would like to know that how the sensitization happened. I will gather some information from my patient. For that, I will take her history, that either the patient is having any history of the blood transfusion and trauma. This is the first time her anti-C antibodies is positive. I will review her records previously, that either the levels are rising or not, and what is her current anti-C body levels, and any history of trauma, any sensitizing event like bleeding, CVS, amniocentesis done in this pregnancy. What about the other NTDs like NTD or not, and either it's the first pregnancy or any previous pregnancy she is having. If yes, then any history of the HTF and hemolytic disease of newborn in the previous pregnancy. If yes, then at which gestational age it happened, and any history of the neonatal anemia or phototherapy baby needs or not, and currently how was her pregnancy so far, and any history of the bleeding and leaking and abdominal pain. What about her fetal movement is fine, and she is aware of the blood group of his partner, and any medical comorbid she is having, any surgeries, because I may end up in the cesarean section. So I need to know any medication she is taking, any allergies, because I have to give the medication, and either the patient smoke or drink alcohol, and what about her mental status. I will ask the police question. Then I will check by checking the anti-C antibody levels. I will counsel the patient that there are some risk to the mother and the baby. To the mother, if the patient need any blood transfusion, in that situation the blood compatible will be delayed, and to the baby there will be the chances of the fetal anemia. If left untreated, it can lead to high drops, fetal death, neonatal death, or the also the after the delivery there is a chances of the neonatal anemia. Baby may need the phototherapy, jaundice. So these complications I will explain to the patient. I will, as this is high risk pregnancy, so it will be managed in the consultant led unit under the MDT, including consultant, and also the specialist midwife, and we will involve the GP, and her delivery we will plan in the center where the blood is available. And if the depending upon the titer, we will monitor. If it is less than 7.5, then I will monitor the level 2 weekly, and I will also check the NTE antibodies, because it can potentiate the severity of the anemia. And if but the titer if more than 7.5, I would like to check that either the previously her partner's blood group is checked or not, either the patient were offered any cell-free fetal DNA or not, and if not, I will offer her, and I will check that either the baby is carrying the similar antibodies as for the father. If yes, then the weekly middle cerebral artery Doppler will be arranged. If it is more than 1.5 millimeters of the median of multiples, then the baby will be referred to the mother will be referred to the fetal medicine unit, or any signs of the anemia. In that situation, also we will discuss with the patient regarding the intrauterine transfusion, and also the risk associated with this, that risk and benefit will be explained of the intrauterine transfusion, that it will correct the anemia, but also it carries the risk of fetal loss of 1 to 3%. But this will be decided by the fetal medicine unit. And so, as my patient is
so the patient is today 34 weeks. So what are you going to do now? What is important at that time?
At that time, I will check her anti-C antibody level currently. And I will check that I will also check her Doppler, middle cerebral artery Doppler. I will check, and so according to that, I will decide her management.
Okay, so what is the management if the patient is now become 37 weeks, okay, and the titer is rising of the Anti-C, and the middle cerebral artery Doppler of the patient, okay, show that there is critical changes.
Middle cerebral artery Doppler is normal, or it's showing critical changes, Dr. Abha?
Yes, it's critical now.
Okay,
so exceed 1.5 of the MOM.
Okay, so now as the patient is currently 37 weeks, so regarding the term, as also the titers are rising, so patients requires the delivery, but this will be decided by the team of the specialist, that the fetal medicine unit will decide that either there is a need of the intrauterine transfusion or not, or either they will do in the during the pregnancy or after the delivery. This will be decision of the MTT, and I need to inform the consultant, and her delivery will be planned with a laboratory where the blood is available, and so regarding the either the mode vaginal delivery or cesarean section, this will be discussed with the patient. Patient autonomy will be respected at the same time, and also during the delivery continuous CTG will be done, and we will one-to-one support will be provided. Anesthetic will going to discuss the pain relief option.
Okay, so what about the advice for the delivery?
Regarding the delivery, patient needs the delivery now, but either the baby is showing as a critical changes, so either the intrauterine transfusion is the plan now or after the delivery. So after the decision about that, then we discuss the her delivery plan. Like mode of delivery, either the patient requires an induction or cesarean section. So after discussion with the consultant, we will decide, and also patient and fetal medicine unit.
Okay, so how about the future pregnancy planning for her?
Regarding the future pregnancy plans, so if I will refer to the patient in the early during the future pregnancies, she will require the early assessment to the fetal medicine unit specialist in all her further pregnancies. And regarding the also during the postpartum plan, I will also discuss a patient that there is a chances that the baby may develop the anemia, and we will regularly assess the baby for the regular assessment of the hemoglobin, and the bilirubin will be done, because the patients baby are more prone to develop the jaundice and anemia, and so neurobehavioral assessment will be checked by the neonatologist. And we will encourage the mother to breastfeed regularly, because dehydration can increase the chances of jaundice. And also regarding the either the baby need the phototherapy or exchange transfer, it will depend upon the bilirubin level of the baby. And
okay.
And also after the delivery.
Okay,
Yes.
so would you please tell me again about which investigation the baby need after delivery?
After the delivery, we will check the baby's blood group, and also the direct antiglobulin test will be done. Hemoglobin level and bilirubin level of the baby will be checked after the delivery. And yes.
Okay. So how about this mother in the future pregnancy? What is the first and important thing that you will do?
Yes, and the future pregnancies, we will future pregnancies. We will, if the baby need any this time, if the baby need any phototherapy or any like the baby developed any complication, so the mother will require the early assessment in the consultant-led unit, in the consultation, the fetal medicine unit.
Will you advise early referral for this mother, or you are going to wait?
No, as I mentioned, that early referral will to the fetal medicine unit will be done.
Okay, thank you. Do you have anything to add in this case?
Also, after the delivery, I will give the patient information leaflet to the patient, and I will document my discussion in my notes, and I will write back to the GP and the midwife about her plan, and I will give the patient now as the patient, and also after the delivery contraception will be discussed with the patient also.
Okay, that's good. Okay, thank you very much. So, any questions so far from your friends? Exactly on time, inshallah. That's great. Hello, everyone. Before we go the feedback to Dr. Reka, any questions? No? Okay, that's all clear. Thank you very much, Dr. Reka. You did great, okay, in this case. And yes, regarding the risk of the anti-C in the pregnancy, I was waiting for you just only in the beginning that you enumerate the risk for me. Okay.
Yes.
So what is the main risk? What is the most important thing that you will...
Baby developed anemia and hydrops and neonatal death, and stillbirth can happen. Jaundice.
Yes. Okay. So I need to please start by enumerating the risk, okay, to the examiner, because what is the first thing
because she asked two questions together, then I thought that it...
Yes. So yes. Okay. So you did great. However, it's just a little bit advice, okay, about the enumeration of your information because it's structured discussion.
Okay. Okay, ma'am.
Right. So I need you to have a perfect performance, right, in your introduction or in your presentation to the doctor. It's not a viva, it's a structured discussion, right? So be structured as well. When you start by, you know, the thing that emphasizes on the importance of this case, the risk to the mother, right? And the you can say a little bit introduction, like it's some antibodies, including D and K and C, confer significant fetal and neonatal risk, such as requiring intrauterine or neonatal blood transfusion, jaundice, or in some cases, a perinatal loss. Okay, so
ma'am.
You show this at the beginning, okay? And you can say also that the anti-C is clinically the most important Rh antigen after the anti-D, okay? That can cause a severe hemolytic disease of the newborn, okay? Just to give the introduction, since you have a very good knowledge of the topic, so just make your presentation perfect, you know? Then after that, you discuss about the antenatal management. It was good also from you, but a little bit of structure as well, okay? The antenatal management specifically in this case, or the antenatal management, okay, in general.
Okay.
Okay, so for in general, and I think this is what you have started with, okay? So when we have a clinically significant antibody screened positive, okay, then we will offer monthly testing or 4 weekly testing until the 28 weeks, okay? And from the 28 weeks, we will test 2 weekly until the time of delivery, right?
So, ma'am, as the patient is already 34 weeks, so I mentioned 2 weekly only.
Yes, that's good. But again, look, my friend, what is the question? What is the antenatal management of patients, not patient one, patient who have anti-C antibody, okay? So here, I will start generally by saying what is the antenatal management of this case, okay? And I will speak about if tested positive, and then I will speak about if it is reached, okay, the critical threshold, right, of the anti-C level, right? So during the quantification or the titer follow-up during the pregnancy, if the patient found to have anti-C level from 7.5 to 20 international unit per ml, okay, this is carry a moderate risk of the hemolytic disease of the fetus and newborn. If more than 20, this is carry a severe risk, right? Okay, so the recommendation nowadays, if we have a patient who reaches that level, that we need to test the baby. And now the cell-free fetal DNA is available, okay, to test for the anti-C in the babies. If the baby found to be positive, right, C positive, okay, so what is the action? Now the baby is high risk of developing the fetal newborn disease, so I will refer to a specialist unit, right, to carry out a fetus ultrasound by expert, the MCA Doppler, intrauterine blood transfusion, as you said, if needed. The plan for delivery will be by the 37 weeks, okay, and the baby after delivery, the cord blood should be tested for the hemoglobin, bilirubin, and that. For that particular patient, so after you speak generally, now make it more specific to that particular patient. For that particular patient, okay, what I need to do now at the 34 weeks or the arrangement for this, okay, that I need to discuss with whom? I need to discuss with
the fetal medicine unit.
No, sorry, the fetal medicine unit specialist, okay, and I need to discuss with the neonatology team, right? And we should have a plan for the delivery for this patient, right?
Yes, ma'am.
Yes, at the moment, okay, our patient level was okay. Now the examiner tell you that at 37, patient had a rising titer, okay, of the MCA, okay, and the PSV is normal, okay? So urgent referral to the fetal medicine unit because baby may need exchange transfusion after delivery, okay? And it is a time for delivery, as you said. So if it is too late for the referral, if now it's exactly 37.
Dr. Abba, your voice is interrupting in between. Hello? No voice, Dr. Abba?
Yes, dear, okay.
Yeah, now
So
fine.
if it is, yes, dear, if it is now at the moment and no time for urgent referral, it's not possible. What are you going to do at the 37 weeks?
Deliver the patient.
Go for the step of delivery. If there is anything to do for the fetal monitoring at the moment, you need to check, right, by CTG for this baby or not. The plan of delivery is going to come next, right? But you have to be prepared for this patient, because if a patient today is 37 and she is now due for delivery, right? I need to make sure that it's safe, for example, to go for induction, is it?
Yes, ma'am.
Right? Okay, so how to make safe, how to make yourself safe in the planning of delivery for this patient?
We will,
yes. You need to check for the delivery plan, okay, for this patient. And if there's any specific instruction given for this particular patient, okay, the obstetric team, neonatal team, the blood bank also should be all informed about the admission for the delivery or for the potential delivery for this patient, right? What investigation that you need to run as a baseline investigation? Maternal group and screen, right? This should be sent immediately on the admission for delivery if there is a potential for the delivery now, right? This is to allow the blood bank for the presence of any further antibody, right? Because if a patient had one antibody, there is a possibility that she will have another antibody, and there will be also a special requirement for arranging a blood match for her, right?
Yes, ma'am.
How about the delivery? The delivery, most important, highlight the big point to the examiner, okay? Sometimes the examiners, they listen, you know, in one circuit, they listen to a 14 candidate, okay? You might be the candidate number 14 in this station, right? Sometimes the examiner is just not concentrating very well with you. Maybe he has a headache, maybe he's tired, maybe hungry, maybe thinking, oh my God, this is the last candidate and they will go. Maybe the previous two candidates before you were too bad, okay, and he's not willing to listen more. He had this thinking, oh my God, this is a very, you know, poor group. Or maybe the candidates before you was too good, right? And you need to prove yourself now in comparison, because it's natural, you know, it's natural. We are all human, that I compare between the levels of the candidate, right? And it's also human natural that I get tired if I am examiner, right? So in this case, make your answer as interesting as much as you can, right? Maintain the eye contact with the examiner, stress on the big point, okay? So at the time of the delivery, very important that you make a preparation for the delivery, right? Among of a team. So focus on the team who are available to help you, right? At the time of admission, I'm doing a baseline CTG for the baby, and I'm sending a blood, and I alert the lab. At the delivery, the pediatrician or the neonatologist, right, should be available or should be attending, right? Assess the newborn, and in some cases will be appropriate for the pediatrician to present at the time of delivery. The attending pediatrician should document the planned neonatal observation and management for the baby, right? Cord blood should be taken for full blood count, ABO, RH group, direct anti-globin test, and serum bilirubin. The tests are very important because they came in the algorithm by the RCOG, right? Maternal blood should be taken for group and screen as soon as practical after delivery. Assessment of antibody level is not required at this stage. If the mother is RH negative and in the same time has not been sensitized to the D antigen, okay, but she's positive for other red cell antibody, then the maternal sample will be taken for the Kleihauer test. This should be collected, okay, after delivery as normal. This sample should be taken at least 45 minutes after placement, the placental separation, to allow distribution of the fetal cells in the maternal circulation. If the fetus is RH negative, RHD negative, positive, and the anti-D immunoglobulin should be given to the mother along with the anti-D guidelines. There is no change, or there is no specific recommendation in this case, no change. Not because the mother has C, we will not give her prophylaxis for D, right? For the post-delivery, the newborn infant may require a phototherapy, right? Sometimes if the anemia is severe, can be a top-up transfusion, or maybe severe enough to have exchange transfusion. This is depend on the degree of the hemolysis and or the anemia present at the time of the delivery, right? Neonates who have required intrauterine transfer have suppressed erythropoiesis and are likely to require a top-up transfusion after delivery, right? So if the examiner told you that the patient had, for example, intrauterine transfusion, what do we expect after delivery? We expected that this baby will need a top-up transfusion, right?
Yes, ma'am.
Blood for the exchange or top-up transfusion must be irradiated if there has been a prior intrauterine transfer. Babies born to mother with red cell antibody may be at risk of severe jaundice, hyperperinemia in the neonatal period, even where there are no signs of fetal complication during the pregnancy as well. So be careful and be aware of the risk of the baby. The mother should be counseled also regarding the risk for the future pregnancies and the need for early assessment, and ideally prenatal counseling should be planned, right? So for the next pregnancy is very important, okay? This patient will be referred early, right? Are we clear so far, my friends? I have a question here from Dr. Amira, and she's asking about what is the best mode of delivery. The best mode of delivery will depend on the fetal status, okay? So if the baby is okay, then the CTG is fine. Go for induction of delivery, no problem of that. Otherwise, if you have something like a contraindication, okay, so please go for the cesarean section, like for example, if you have a fetal distress.
Dr. Abha, I want to ask one question. Should we gather the information in this patient or not? Like you start, we will not gather the information. How we know, doctor, this?
No, you gathered the information. Your gathering information was very good in the antenatal management. I didn't comment because it was perfect.
Okay. Thank you.
Okay, dear. Yes, of
Okay.
course, you have to know what is the risk, why this patient have anti-C positive. Is this patient had a blood transfusion, as you said, did she had a bleeding in the current pregnancy? What about her placenta previa? What about the C level at the moment? What about the other antibodies and maternal anemia? Yes, of course. What you have covered was so brilliant, actually.
Okay, thank you, ma'am.
Yes, dear, you're welcome. Okay, my friends. Okay, so are we ready to move to the next one?
Yes, ma'am.
You are welcome, Dr. Rika, my dear. You are welcome, of course, anytime. And all the best, my dear, in your result. Okay, so I'd just like to know who is my volunteer in the next. Okay, so this is Dr. Tabinda. Yes. Dr. Amira, do you have any question? So, Dr. Tabinda, dear, are you ready?
Ma'am, I'm unable to see the screen.
Hello? Yes. How are you?
Hi, ma'am. How are you?
I'm okay. Hello?
Yeah, ma'am.
Okay, so I just have a problem in sharing this particular presentation. I don't know why. Okay, so just I'm trying to solve this problem. However, I would like to save your time. Okay. And I would like to give you a chance, prepare yourself for a presentation about ovarian aging. Okay, will you be able to present this ovarian aging for us?
Okay, ma'am.
Okay, so Dr. Tabinda, are you okay? The sound from your side is audible to everyone.
Hello. Yeah, ma'am.
Hello. Okay, so a little bit of, I think there is some echo or something around.
From my side?
Okay, so I will. Okay, so yeah. Guys, can you hear Dr. Tabinda well?
Yes, ma'am.
Okay, that's okay. Okay, so Dr. Tabinda, dear, take your time. Okay, and when you are ready to present, please let me know.
Okay.
I'm sorry that you can't see the task. I have a problem in the sharing. I don't know why. I'm so sorry.
So
But
ma'am,
I can read the task for you that you are at the ST3 in the unit, and you've been asked to share in the unit meeting, okay, with a new topic, okay, of the early ovarian aging. So the task from your side is you prepare a presentation for the early ovarian aging and introduce this presentation to your colleagues.
okay, ma'am.
Okay, so are we ready, my dear? It passed 2 minutes now.
Yes,
Hello?
ma'am.
Yes, please.
Yeah,
Okay.
ma'am.
Okay, I started your
Hi.
timer. Okay,
Yeah, yeah.
I started your timer, and
Hi,
please go
I'm
ahead.
Dr. Tabinda. Yeah. Hi, I'm Dr. Tabinda. I'm ready for the structured discussion.
Okay, so Dr. Tabenda, as part of the activity in the unit, okay,
Mhm.
we would like to arrange a meeting to update the junior colleagues about the topic of early ovarian aging. So
Okay, ma'am.
I'll ask you to present this topic to your colleagues, okay? So would you please tell me, how are you going to arrange this?
Okay. The early ovarian aging means that there is an amenorrhea or disturbed menstruation or irregular menstruation and elevated gonadotropin and estrogen deficiency before the age of 40 years. It means that it is before the age of 40 years, there is some loss of ovarian function. So we call it early ovarian aging, and it occurs in 1% of the women under the age of 40 years. And there are so many causes of this early ovarian aging, like the most common cause that is idiopathic. It could be due to any autoimmune causes, due to genetic causes. Could be due to any disturbance in karyotyping like Turner syndrome. It could be due to any surgery, due to surgical removal of ovaries after any treatment of cancer, like after radiotherapy or chemotherapy. It could be due to infections like mumps, tuberculosis, and tuberculosis. And there are some chances that it is related to the family history and we will ask the patient about her menarche also, about the menarche, that what happened when she attend her menarche, and uh, uh, and that's it. And about now coming towards the investigation, that how we diagnose premature ovarian insufficiency. So there should be a amenorrhea of 3 months. Then we will ask the patient for the testing of serum FSH, 2 levels of serum FSH 4 weeks apart, and the levels should be more than 30. We will diagnose that it is the patient of premature ovarian insufficiency. The estradiol levels would be low, and there is a estradiol level will be low, and there is a there is and we can also, in some patients, we can also go for the karyotyping, in which we suspect the genetic causes like Turner syndrome. And ma'am, now
Yes.
for the ma'am, now towards the symptoms of premature ovarian insufficiency, that there would be irregular, there would be primary or secondary amenorrhea, and hot flushes, night sweats, loss of libido, irritability, and less sexual desire, and less sexual desire, and less sexual desire would be there, and then about the management of this patient. First of all, this patient who has premature ovarian insufficiency, as the estradiol level would be low, so the patient would be at greater risk of cardiovascular disease. So lifestyle modification and would be the first, and we can create an MDT team for this patient, which will have consultant gynecologist and a psychologist and a dietitian, and dietitian would be there. And for this patient, first of all, we will give this patient hormonal therapy till the
Hello?
hello.
Yes, my dear, please continue. I'm thinking that the voice was only interrupted. Yes, please continue.
Yeah. We will give this patient a hormone replacement therapy or hormones till the age of 51. And if she wants to conceive, if she wants to conceive, that there are 5% chances that this patient can conceive spontaneously. And we will also check this patient the serum AMS to see the ovarian reserve. And if the ovarian reserve will be very low, we will offer this patient different options for the fertility, like adoption and surrogacy and IVF pregnancy, like adoption and IVF pregnancy, and IVF pregnancy. And as the patient has psychological problem, and we will refer this patient to the psychological counselor also. And if she want have fertility issue, we will connect the patient to the fertility specialist. And that's it, ma'am.
Okay, so if there is anything else would you like to cover in your presentation?
No, ma'am. The complication in this patient could be that she may suffer from the osteoporosis because of loss of estrogen. Loss of estrogen will lead to the decreased bone and density, and the patient could have cardiovascular complication. The patient could be patient of Alzheimer's disease, and I will also place this patient on HRT for the symptom, because he may experience the symptom of menopause. Thank you, ma'am.
Okay. If there is any model that you would like to follow in your presentation?
Ma'am, I was thinking that I will go like from definition and then causes and symptoms, and then investigation, and then treatment.
Yes, okay. Okay, there is no problem, my dear. You're welcome. You have covered the knowledge nicely, okay, which is thing that I admire from you, okay. And regarding the knowledge, we can cover it together or go through it together, okay. I just want to check your timer. Yes, so you have finished too early, no problem, okay. So I just close the timer for you. Okay, so regarding the knowledge is, as you can see here, okay, that you mentioned about the facts, okay, about the ovarian aging. So you mentioned about the management of the ovarian aging, but if you have noticed, my dear, that what the consultant requested from you, do you remember what was the request of the consultant at the beginning of the task?
To describe your colleagues and arrange a meeting for the earlier meeting.
Yes.
Describe this topic.
Yes. So the consultant asked you, okay, that you arrange a meeting with your colleague, right? Right? Okay. So if you are arranging a meeting of a colleague, okay, how are you going to organize this meeting? Do you think that a presentation skills is required in the NHS? I'll tell you, dear. Yes, it's required, okay? It's a part of the answer. It's a part of the answer, and it's part of the skills that are required for doctors in the NHS. It's not only about that you have the knowledge, it's about how are you going to arrange a presentation, okay? Or how are you going to prepare a presentation for your team, okay? For your colleague. It's about presentation skills, right? So you start by the frame of the presentation. What are you planning to present it to your colleague, right? Start from the importance of the topic that you discuss, right? Selection of the topic, right? Then you come to the point of audience, okay? So do you think that selecting audience, or at least, okay, mentioning who are the audience to attend this meeting is important? Yes, it is, okay? So I would like to start by the importance, okay, of the topic. So what is the importance of this topic, my dear? The introduction, your lovely introduction should be about the importance of the ovarian aging. So please tell me, what is the importance of this topic?
It will tell about the why irregular menstruation occurs in the early age. It tells you.
This problem is nowadays more significant than before or not? Is it something that we see nowadays more common in practice or not? Yes, it is. So, do you think that they change it in the lifestyle and the you know, how the people work and how the people, you know, marry and maybe delay their start of the family is a factor of that why we see this problem nowadays? Yes, it is, my dear. Okay, so just, yes, it's the increase in conception age, okay, delay of the day or the age where the families start to think about children, okay, or having the first baby. So what we see nowadays, we see females, okay, that are so busy to start their career, their own career, and then after they establish a career, they start thinking about their family making, right? Establishing a family. So what will happen is that we have more patient who comes to us, okay, to visit us in the fertility clinic or even in the gynecology clinic, and we will be surprised that this female nowadays, she had a problem, okay, with the ovarian, or the quality of the egg, or the ovarian aging. This is what we see nowadays, right? Okay. So yes, it's important to discuss about, okay, about the importance, why the ovarian aging nowadays become a trend, okay, and why the college, okay, have arranged, or there is a new TUG article about that. I would be smart and mention this to the examiner, okay, that what is the ovarian aging, what is the importance of that topic, okay, and how does it become a trend nowadays, okay, even it's published in one of the recent TUG article, right? So this is in regard to the topic, okay, selection of the topic. The next thing is I need to build my presentation. So I need to invite audience. Who are your audience?
Okay. Doctor.
Okay, so what kind of a doctors?
Ma'am, gynecologist.
Okay, so doctors, is only doctors, and what level of doctors? Is it junior doctor? Is it senior doctors? Middle grade doctors?
Nurses, yeah.
Trainees, yes, all. So you need to, to invite juniors and also your seniors and your colleagues. So that's mean all levels, right? Okay. Do you need to invite your nurses as well?
Yes, ma'am.
Yes, sure. Do you want to invite GBs or GB trainees?
It's good to invite GPs because it's a very common topic.
Yes, right. It's a very common topic. So you need to decide who are your audience in your presentation, right? So very important, okay, to discuss about the topic, then discuss about the audience who will attend your presentation, and then speak about how are you going to plan your presentation, right, for the audience, how to make it interesting, right? So first of all, you will develop an outline for your key points, right? Think about 3 or 4 key points that you want to share with the audience and organize them into a concise outline. Yes, use of the PowerPoint presentation, basic. Decide on the right structure of your presentation. You have to determine a clear beginning, middle, and end of your presentation, right? You have to offer, okay, a time for your friends or invite them, okay, to ask questions, right? Correct? You can prepare, yes, well done. You can prepare a handout after your presentation. You might even have a small quiz. Is that correct? Okay, discussion or a take-home message, okay, after a few questions, like can be true or false questions, or can be single best answer questions, just to ensure that the audience have absorbed the topic correctly, right? So the importance of the presentation skills in this task is very important. And people think that I know the ovarian aging, I've read the TUG article of the ovarian aging, I just said everything I know to the examiner about the ovarian aging, okay, so I have passed the task. It's not correct. Unfortunately, it's not correct. Okay, so if you just approach it as a tutorial, or as Dr. Rabah asked me here, she was my examiner now, and she asked me about the early ovarian aging. How are you going to present a presentation about early ovarian aging? So I told her about 1, 2, 3, 4, 5 points and finished. Okay, this is not the purpose of this task, my friend, about how to approach it. Okay, it's testing your presentation skills. Part of the assessment of doctors in the NHS is not only, and by the GMC, is not only their knowledge. It's how they work in a team, okay? How to work with a group, okay? Leadership and management. Part of that, okay, that you are participating with a group, so you are preparing or arranging a presentation to your colleague, how to show that you have a good presentation skills. If you have a good presentation skills, that's mean, okay, you are involved well with your group, and the aim of or the purpose of this presentation or this meeting, okay, were fulfilled correctly, right? So this is what the examiner want to hear first, is how to go through the presentation, okay, and show the examiners that you have some of the presentation skills. That is what we do in our hospitals, my friend, right? So if you are invited to share a presentation in any place, right, what you do? You prepare yourself, why you choose the topic, why this topic is important. You plan who are the audience, okay? How are you going to present nicely in a concise point? You have some point or outlines, right? Purpose of this presentation, and use colors, maybe use graphs, pictures, okay? A nice interactive presentation, okay? You can make it in a bullet point, you can make it in a question and answer point, okay? You can include a quiz at the end. You give time to the attendants to ask you question, okay? You maybe prepare a summary, a take-home message, okay? Or a printed summary with them, right? Yes, Dr. Tanya, exactly, okay? So here, my friends, okay, I need to start with very important thing in my topic, okay? Why did I choose the topic? Why this topic is important nowadays? Yes, we have covered this point. What is the difference between ovarian aging and insufficiency? This can be a very interesting title to my presentation, right? Or a very good question to start with, right? So, my dear, I will ask Dr. Tabinda, because she is the star of this task today. Dr. Tabinda, dear, what is the difference between the ovarian aging and the insufficiency? Because it's very important to tell that to the candidate, right? To the audience.
Ma'am, I was not getting the difference. I think that in premature ovarian insufficiency, that the patient is near to menopause, and in early ovarian aging, that she's young and her ovarian function are getting decline. I was thinking that this.
Okay, I think you have a good idea. Okay, I think you have a good idea. So don't, doubt yourself, my dear. Okay, so trust yourself and be more confident, Dr. Tabinda, dear. Okay, so Dr. Rika want to answer this question. So please, Dr. Rika, come on.
Yes, ma'am. In premature ovarian insufficiency, there is the patient will be symptomatic. She is having the symptoms of the menopause, but the early ovarian aging patients does not have the symptoms of they have the regular periods. So they will not diagnose until they go for the fertility treatment. Like when we investigate them, at that time we will diagnose them. And also they have the FSH mildly elevated, maybe normal. But in the premature ovarian insufficiency, they will be markedly elevated FSH level. And there is only 5% chance of the spontaneous conception in the premature ovarian insufficiency, but in the early ovarian aging, they have the good chance of the conception if they conceive in the young age. But their ovarian reserve will decline in the late 30s, so we will counsel them to conceive as soon as possible.
Yes.
And also they will not require any treatment for the, we are giving HRT in premature ovarian insufficiency, we are not giving in the early ovarian aging.
Okay, thank you very much, my dear. Thank you. Okay, so guys, let me go through this nice summary of the TUG article, okay, made by our team today. So the ovarian aging that affect both oocyte quantity and quality. Oocyte quality decline from around 31 years of age and account for the increased risk of aneuploidy and miscarriage, right? That's why we have the increased risk of aneuploidy and risk of miscarriage after this age. We even think about it from the 35, but it started from 31. The reduction in quality is thought to result from age-related increase in the mitotic non-disjunction, combined with preferential recruitment of the highest quality oocyte for ovulation. A variety of mechanisms have been suggested, okay, for the underpin the decline in the oocyte quality. Maybe genetic factors, genomic DNA alteration, mitochondrial DNA mutation, or reduced the telomerase activity. Also, some microenvironmental changes like the oxidative stress, which is surrounding us everywhere, the advanced glycosylation and products, and the the free radicals, in the pollution or the environment to surround us. So what is the early ovarian aging by definition? Okay, so we need to discuss definition, terminology, and epidemiology. So there is no standardized diagnostic criteria, okay, over the what is called, okay, early ovarian aging so far. So it's a hypothesis, okay? The hypothesis suggested that early ovarian aging follows a similar model of follicle loss to normal ovarian aging with relatively fixed reproductive milestones. However, the onset of the ovarian aging process occurs significantly earlier rate, okay? Young women with reduced birth rate in the early stages of marriage and earlier age of the last children, 35, suggested that the loss of fertility was preceded by a period of reduced fertility as well. Okay? So here is a comparison from the TUG article between the early ovarian aging and premature ovarian failure or insufficiency. Okay? Okay, so here in this differences, it's a table number 1 in the TUG article, so it is the very first to start with. The early ovarian aging, it had 10% prevalence of patient will have regular period, patient will be asymptomatic, okay? The FSH normal or mildly elevated. The estrogen replacement not indicated, okay? And the fertility preserved until late, okay? So, shall I give HRT for this case? No.
No.
Doesn't need, right? How about the premature ovarian insufficiency? The prevalence is higher or lower than the early ovarian aging? It's much lower. It's 1%, okay? Periods are regular or not regular with the premature ovarian insufficiency? In the premature ovarian insufficiency, it's oligoamenorrhea or even amenorrhea, right? But early ovarian aging periods are regular, okay? Okay. So the patient have symptoms of premature ovarian insufficiency, yes or not? Yes, it shows symptoms, right? So the patient may show symptoms of estrogen insufficiency. How about the FSH? This is a very important thing. It's markedly elevated, more than 25 to 30 international unit per liter. The patient need HRT or not?
Yes, needed.
Yes, of course. Estrogen replacement is advised. Okay, of course, for any woman who have a uterus, we must have estrogen plus progesterone. A chance of the spontaneous conception is low. It's around 5% that can happen spontaneously with the premature ovarian insufficiency, right? But with the early ovarian aging, okay, there is a fertility until late, right? Correct, my friends?
Yes, ma'am.
Okay, so it's the term of the early ovarian aging, okay, refer to a condition in which there is low ovarian reserve at a young age and accelerated loss of ovarian follicle in the early 30s. Okay, so this patient who have early ovarian aging, she might reach her menopause when? She might reach her menopause earlier, okay, but not around the 40. Early ovarian aging, she will be around the 45. Okay? Insufficiency is around which stage? Which time, which age? Before
Less
40
than
or
40.
40?
Less than 40.
Okay, it's 40, yes. So it's before the 40, right? So the patient who had insufficiency, she had a cutoff. She had secondary amenorrhea or oligoamenorrhea before the age of 40 with elevated FSH, and she had a significant problem, of course, that affected her life and fertility and else, and even had health consequences like the osteoporosis, heart disease, and affected cognitive function, right? This is about the patient who had insufficiency. But the patient who had ovarian aging, she started early, okay, to lose a large number of follicles, okay, so she finished early her follicles, okay, but this is not before 40, it's usually around the 45 or before the 45. Okay, guys, you got the point? So
Yes, ma'am.
one have a shut off and another one have accelerated rate of loss, okay, of the ovaries. Also quantity and the quality, both of them. So if this patient is undergoing a treatment, ovarian IVF treatment or fertility treatment, the outcome is not going to be great because of the reduced quality of eggs, not only quantity, okay, of the early ovarian aging. So how about diagnostic criteria of the early ovarian aging? Uncertainty is the main guest in this topic, okay? There is no standardized diagnostic criteria, okay, or consensus also about the early ovarian aging, that, as you can say, okay? So what is the main problem that the patient come to us and we will discover that she had early ovarian aging? What will make the patient discover this?
When they come for the fertility treatment.
Yes, it's mainly the fertility is their problem, okay? And what we will see, we'll see some markers like low ovarian reserve, okay? Raised of the follicle stimulating hormone, but it's not very marked raised like the insufficiency. We will see reduced antral follicle count, okay? And we will see low anti-Mullerian hormone, okay? But this will become apparent late, okay? So the early diagnosis will therefore require serial assessment of the ovarian reserve markers and comparison with age-matched normal values, okay? So the fertility workup will markedly change late, not early, right? But nowadays, they want all doctors to be aware of that problem so they might catch it earlier, okay? Before things become too late, before the situation gets worse, okay? Okay, so how to do the early diagnosis? Early diagnosis will not come unless you did a serial assessment of the patient for the ovarian reserve and compare this with the age group, okay? The normal values of the age group. And then you will see that this patient have the decline in her fertility is coming fast. Okay, guys?
Okay, ma'am.
At present, unfortunately, most of the women with the early ovarian aging are only diagnosed relatively late because to be practically speaking, it's not possible actually to monitor all the women. Is that practically possible? No. Okay, so unfortunately, what we will find is late presentation cases, okay, when they come with a problem of the fertility. So they have at the onset of the moderate abnormal ovarian reserve test, such as the FSH value will become around 10 to 20, antral follicle below 4, and AMH below 5, okay? But the woman will be younger than 37, right? So the woman is still not in the menopause or the ovarian insufficiency, but she had bad function. She had low reserve early in age. Okay, so again, my friend, at the time of the presentation, most of the cases will come late, okay, in the late stage of aging. What do you expect to find, for example, in a patient less than 37? How about her FSH? I give you choices, my friend. 5 to 10, 10 to 20, 20 to 50, 25 to 30. What do you think?
10 to 20.
10 to 20, excellent. Okay, how about the antral follicle? Is it 12, 8, 10, less than 4?
Less than 4.
Less than 4, excellent. How about the AMH? And you know the relation between the AMH and FSH. FSH increase, AMH decrease.
Decrease.
Right? So the AMH will become below 5 in this case, right? So those are
Yes,
criteria. So you might diagnose a case of early ovarian aging, for example, in exam, if he give you Miss XY, okay, no, not XX, not Miss XX, Miss XX, she came to you and she is 36 years and her FSH level is 11, her AMH is 4, her antral follicle is 3. What is this condition?
early ovarian aging.
Yes, this is early ovarian aging, right? Okay, so how about the quality? Do you think that early ovarian aging is associated with reduced quality as well?
Quantity is reduced and the quality will preserve until late.
The both reduction in quality and quantity and quality, both together. Okay, so what we can see here, okay, it's a cumulative, you know, effect of the DNA damage. Okay, so if the woman had early ovarian aging, but she came to you early, like at 31, is that better outcome? Or a woman who had early ovarian aging, okay, and she came to you at 36, which one have better outcome?
31 is a better outcome.
Yes, of course, the 31 is better off, right? Why? So,
because of the age, the NUPID miscarriages and quality will be reduced also, egg quality.
Yes, so the egg quality is better. The younger the egg quality, the better, right? And what we have seen even, okay, that even if a woman had early ovarian aging, she will have normal fertility when she is still young, okay, around the early 30s. There is no problem for them if they conceived at that time. Okay, so what is the general advice that we say to our patient, or if we speak about health awareness to the females, what we will advise?
We will say that to complete your family as soon as possible.
Yes, she can complete her family, and there is another option, by the way, and they can come to you in a counseling patient, like for example, preservation, right?
Oh yeah, egg preservation, yes.
Yes, sure. Okay, that's why this topic is related to the topic of egg freezing and preservation. Okay. Okay, so genetic factors might be the cause. If we ask about what is the etiology, mainly genetic factor, environmental factor, where the woman was a fetus at the time when she was a fetus, she might been under stress. Okay, endometriosis found to play a role, infection found to have a role, autoimmune disease, smoking, okay, or drugs like the chemotherapy or radiotherapy, all are playing a role in reducing the age or the egg quality and the quantity, and accelerate the rate of loss. So increase the ovarian aging. Okay, my friends? Okay, so what is the reproductive and general health consequences? Okay, they will have earlier loss of fertility than their peers with normal ovarian reserve. Okay, but they are not infertile. To be clear, okay, they have low chances. They have low fertility, especially if they become at the age of 37 and you know, older, but they are not infertile patient, okay? There is the chances of natural conception or not, even if the woman is affected by early ovarian aging, especially in early to moderate cases. Yes, there is a chances, okay? And the natural conception rate is possible, and the success rate following ART is still good if the woman comes to us early. That would be good, okay? In a woman with sufficient ovarian reserve who are ready to start a family, natural conception remain an option for them, okay? However, early investigation for other causes of fertility is recommended, okay? If there is any increased risk of aneuploidy and a miscarriage rate, what do you think?
Will be increased because egg quality is reduced.
Yes, ma'am, increased risk of aneuploidy, high rate of miscarriage.
They can have, yes. So yes, so in a largest observational study to date, based on the UK data, okay, from large number of IVF pregnancy, 124,000 and more, the young women with poor response to ovarian stimulation had higher rate of miscarriage than those with good response. Okay, so yes, it affects. Okay, guys, and this is regarding the premature ovarian insufficiency and early menopause. It has been known for many years that the woman with poor response to ovarian stimulation for ART have a higher risk of early menopause. A lower age matched AMH and antral follicle count are associated with earlier age of menopause. So serial assessment that take into account individual variation in the rate of AMH decline can enhance the prediction. So dear friends who are asking about the premature ovarian sufficiency, is it a subset of early ovarian aging? I can say that this is like in the stage, early ovarian aging. You got my point, my friends?
Yes,
So
ma'am.
early ovarian aging can be due to the accumulation of the DNA damage due to environmental factors, genetic factors, okay? It go, okay, gradually, but it accelerates rate from the 30s, from 31 years. The woman will still be fertile. She still can have pregnancy, okay? She will have periods and almost no symptoms. We discover those cases when they come to the fertility, fertility clinic because of the reduced fertility with time, okay? If this woman comes to us to the fertility clinic who have early ovarian aging, she will be a poor responder, okay? She will not respond nicely, okay, to the treatment, to the fertility treatment. So if the woman had poor response, my friend, what do you expect regarding her future menopause? Do you expect that she will reach early menopause, or she will have her menopause in the usual time around 51 years? What do you think?
Early menopause.
She will have early menopause. That's it. Okay. So the patient who have poor response to ovarian stimulation for ART have higher risk of early menopause. The patient who have lower age matched AMH level and antral follicle level will associated with higher risk of early menopause. Okay, my friends?
Okay, ma'am.
Okay, so I want you, my dear friends, to get a home message, okay, take home message from this, that the early ovarian aging, okay, is a risk. It's an environmental risk, and it is increased now to the socioeconomic status, okay, and the delayed date of conception or the delayed date of starting a family in the whole world. It's not only the Western world, it's now in the whole world. They have the same problem, okay? So it's not absolute cause of subfertility, okay, but it's reduction of the fertility with time because of the higher accelerated rate of the egg loss, okay? both reduced of the quantity and the quality. When this patient comes to us in her mid-30s or late 30s, she might present with the subfertility problem, okay? She tried for pregnancy and it takes longer. What we will find in her test is we find that mildly elevated FSH, okay, like we said, 10 to 20, for example, for a woman who's at the age of 37. We find the low antral follicle count, less than 4. We find that the MH is low as well, less than 5. This is all associated with poor response to the IVF. And we can predict that this woman will have early menopause as well, with all the health consequences of the early menopause. What is the requirement, or what is our rule? Okay, our rule is raising awareness in the population, okay, to increase risk of early menopause. This is the rule, and this is the aim of the presentation. That's why we do this presentation to our colleague. Okay, my friends, what the patient can do or a woman can do to improve her ovarian quality, okay, is lifestyle modification at the moment, okay? Are we clear so far?
Yes, ma'am.
Okay, so I think that we came to the end of our meeting today. I was so happy actually to be with you, my friends. And to be honest, I was very tired in the morning and I didn't have the best, day in my life today, alhamdulillah. So, but after this meeting, I feel much better. So it's always a pleasure, my friends, to have you.
Thank you so much, Doctor.
Thank you, my friends. Okay, keep on practicing, my dear friends, and practice in a smart way. Okay, present in a smart way. Remember the principles of counseling, the principles of presentation, and dealing with your colleagues in the exam is not only a recall of knowledge, it's about the techniques. Okay, dear friends, thank you very much. Thank you very much, Dr. Islam. I'm so happy to have you today. Next time, inshallah, you will present the first task.
Thank you, Dr. Dava.
Thank you. Bye-bye.
Bye.
Thank you, Dr. Tabenda. Thank you, my friends. Jazakallah khairan, Dr. Anam. Thank you, Dr. Amina and Dr. Tania, Dr. Amira, and Dr. Reika and Dr. Sarah. Thank you. Assalamu alaikum. Bye.